Now we are going to start with the next session. What we are going to cover here is processing of the semen samples for IUI IVF. We are going to talk a lot about sperm morphology and the classification of abnormal sperms. We are going to show you slides. There are a lot of slides which we have bought, which all can see later, but since we are little short of time today, so we have to try to condense everything in the next 1.5 hours. The last bit will be on newer sperm function tests, if we have time, depending on how hungry everybody is and how much time is left. So, we can continue how much ever time, that's fine. I don't, the other people who are speaking might have a problem with that. Okay, sure. Okay.
Let us start with the second session, which is a processing of the semen sample. Now we have two techniques, main techniques. One is swim up and one is density gradient. Swim up means you use only culture medium to get the motile sperm, which will swim and come up to the periphery of the tube. That is the reason it is called swim up. In density gradient, we use two different concentration of the density, per col gradient, can say. And we separate these sperms, motile sperms and good quality sperms, from the non-motile and the infectious sperm. It is said that, it is proven in fact that the density gradient can reduce the viral load up to 95%. So if you have the infected sample like HIV, HBs, AG, in that case also you can use density gradient. So when you have low count, density gradient is suggested. When you have good count, yes, you can use the swim up technique. Now the basic difference between the concentration of the sperms by using both the technique is, in swim up you will get the good quality sperms because whoever are good, mature, will swim and come up. While in density gradient you are doing centrifugation. By doing that we concentrate everything which is motile. So you get more concentration in density gradient while the concentration is less in swim up, but whatever sperms you will get, they are absolutely normal. So, but when you do IUI, in that case, if you have good sample, you can do swim up. Otherwise, you have to do density gradient to get the proper concentration. So now we will do both the methods together so we can save time. Here, because of the time limit, I have to wind up the method little early. So instead of waiting for 20 minutes for centrifugation, we will finish it in 10 minutes so we can save our 10 minutes there. I will explain your entire process. For sure, you will get all the knowledge. But we will not wait for the centrifugation because in that 20 minutes we have nothing to do. We can take questions, but we don't have, that much of time. So we just wind up the process little faster. But I will explain you the entire process so you can note down, and it is also there in your this pen drive. I have already given the method, so you can go through, and even if you have queries after that, I will give my email ID and contact number later after the session, so you can always contact me for further queries, and sir is anyway there to guide you, right? So let us start without wasting much time. Now we have a sample and we have to process two methods. One is swim up and one is density gradient. I would like to tell you lab weights which we use for the method. One is round bottom tube. This is for swim up. We always do swim up in round bottom tube because they have to swim up. For that they require more surface area. That is the reason we use round bottom tube. When you do gradient, it means you are going to do centrifugation. So whenever there is a centrifugation, you use conical bottom tube. So you get the better yield here. Because you will get the compact pellet at the bottom of the tube. So whenever you are doing centrifugation, use conical tube. Then we have transfer pipette, individually sterile transfer pipette. One pipette you can only use for once. You cannot repeat it. That is the thing in IUI. So it is very costly. And then we have media. There are two types of media. One is sperm wash. See, the name differs with the company. So the broad name is sperm wash. And other is density gradient, which has different concentration available in the market, readily available. One is 80-40, 45-90, 50-90, 55-80. So whatever concentration you are comfortable with, you can use. There is not much difference in the yield, whatever concentration you use. Because they cannot copy the same concentration, the different companies has designed the different concentration. That's it. Or else you can take the 100 ml stock solution and can divide according to your need. If you want 50-80, you can prepare 50-80. If you want 40-80, you can prepare 40-80. Right? Here what we use is, we have two options. One is 40-80 and one is 55-80. These are readily available. We just have to prepare the tube and you can use the medium. Now, you will also need heating block for the swim up. So these are the this is the setup which you require for the IUI. Now let us start with the procedure. The very important thing is labeling. If you have 10 samples. And one more thing I would like to make a point here, that whenever you do semen processing, handle one sample at a time. There are two reasons for that. One is mismatching. You can, by chance it happens, then there is a big problem. And second thing is contamination. Big point I have made, I know. If mixing of sample happens, then you can create so many things. So that is the reason. Of course, like some fair, if you mix the sample of fair person and the dark person, then anything can happen. Anyway, leave that part apart. Then there is a second thing is for the reduce the contamination, always use one sample at a time. The point is you use one sample at a time. When you're labeling, always make sure that you label both the things, cap or lead and the tube. First we do the swim up because it takes 45 minutes. So we take the sperm wash medium. For swim up, we take sperm wash medium and the semen sample. These are two requirements for swim up. We take round bottom tube. See, it's always 1:2 when you do swim up. If you have 1 ml of the sample, you take 2 ml of the medium. Avoid air bubble because bubbles are troubles always in IVF. See, you have to load the sample underneath the medium. So now you have to go down at the bottom of the tube and then load the sample. Now this tube will go at 37 degree temperature for 45 minutes to 1. Now we will put this tube at 37 degree temperature for 45 minutes to 1 hour. See, now it is about the not only the temperature but about CO2 as well. If you are using the medium which has bicarbonate buffer, in that case you have to use CO2 incubator. If the medium is containing herpes buffer, it is not CO2 dependent, so you can use a normal incubator or maybe a heating block. So now this medium contains herpes buffer, so we don't require CO2 incubator. I will keep this tube in slant position, so we have the better surface area for the movement at 37 degree temperature for 45 minutes to 1 hour. See, swim up you can do, there is one more method to do swim up. First you centrifuge the sample with the medium. Whatever pellet you get, you can put that pellet for the swim up. That way also you can do. Or first you do the swim up. Whatever supernatant you get, you can wash it afterwards. So there are two things. Hope nobody is confused. Both are equal. You can follow anyone. See, you know the methods. Divide the sample, perform it in your lab. Whatever is giving you result, follow that. Best way to choose the method. Fine? So now this is about the first step of the swim up. Now we have 45 minutes. In that time, we will do the preparation for the density gradient. Right? So I am moving to the density gradient. We need conical bottom tube, different density gradient medium. I have 55, 80 right now, lower and higher, and sperm wash. Three things are required for the density gradient. First, you prepare the gradient tube in which you take higher density, lower density, and then medium will come above it. But here I will do reverse. First, I will take lower density. Then underneath I go and load the higher density, so we have a better interface. Interface is very important in density gradient because that interface will act as a filter. Everything will get filtered at the interface. The immature sperm, unwanted debris, everything will get filtered. It will stuck at the interface, and whatever you get at the bottom is the pure sperm. Concentration of the motile sperms and good quality sperms. So if you don't create the interface, you cannot get the proper yield. That is the reason I go underneath and load the higher density. You can do higher density, lower density, and sample. It's up to you, but the main thing is interface has to get created.
I think I will just explain to you which method to use in which clinical situation, because that you may not be aware. Now, if your counts and motility are reasonably good, you can use sperm wash and swim up because it's very easy to perform, less expensive. If your counts are low, or if your sample has too many pus cells or debris, then it is better to use the Percol gradient. The reservation about Percol gradient are, these are silica particles, and the reservation was that when you use it for IUI, whether the silica contamination gives rise to any abnormality in the baby. But there are enough papers published till now which show there is no such ill effect. So you will see about 80% of the time any IVF clinic will be using Percol gradient, that is density gradient, over sperm wash and swim up, because their patient clientele is coming with low sperm count only. So to attempt, just now I was having a discussion with somebody, if your count is say 2 million with 20% motility and you do a swim up preparation, is not going to work. You know that with that count and motility you need to use a density gradient. So you can't apply swim up method to a situation where your counts are going to be 2-3 million with 20% motility. You can then necessarily use only per call gradient.
Here the ratio will be 1:1. Like if I take 1 ml of the sample, you have to have 1 ml of the gradient. Lower density first, then I will take higher density. Please hold the mic. See. Hello. I have taken the lower density. Now go underneath and slowly release the higher one.
Can you please show it on the screen?
Just a minute. We can do one thing. I'll give you all a tube and the medium. You can do at your place. Here only, within the 10 minutes. You can try your hands here. Then now we put the semen sample, mix it properly. You can took both. No, it depends on how you load it.
Now if you load it differently at the interface.
See, now we take sample at the top of the tube. So there will be 3 clear layers. I'll show it to everybody. Yes. See, 3 different layers can be easily seen. Right? See. Semen sample. This is the frozen sample, that is, it is equal. Yes, this is 2, 2, 2.
So this is semen, this is
Lower, this is higher, this is lower, and then says the semen.
And it will get separated at interface.
Because it is frozen sample, it is prepared with the medium, so it is pinkish in color. Right?
semen sample is
Up.
you are released from here.
No, semen sample I put it at the bottom, sorry, at the top. See, first you take lower density, go underneath, release the higher density, and semen sample at the top. There has to be 3 clear layers. Yes, this is 2 ml. Yes. See now. This is higher, lower. Higher will come down.
But anyway, we can interchange.
Yes. But the main thing is interface has to get created.
Okay. All the 3 layers should be seen properly.
Yes. 1:1 means equal amount of sample. Like if you have 1 ml of sample, you take lower density 1 ml, higher density 1 ml, and semen sample 1 ml. 1:1:1.
Will be the medium and 1 ml will be the semen.
Correct.
So it's not 1:1.
1:1. 2 different density we are taking.
Low density 1 ml.
Yes. Sample 1 ml. Sample 1 ml. So 1:1:1. Right?
But reverse is also possible, no? Because semen then...
No. In density, semen has to be on top. Because you are going to centrifuge it. Whenever you do centrifugation, whatever you get is the pellet.
So high density is your interface.
Between the high density and low density is the interface. Two densities are meeting at the one point, that is called interface.
Semen.
If sample is less than 1 ml,
Then you take 1 ml, 1 ml and 0.5 ml of the sample.
whatever the sample quantity.
Yes.
We should consistent with 1 ml of reagents.
Yes.
Whatever be the quantity, if it is more than 1 ml, then 1 ml.
No, if it is more than 1 ml, then you have to take more media.
Okay.
Yes.
It is, suppose the sample is, I received sample 2 ml sample received.
Then you take 2 ml, 2 ml, 2 ml.
Okay.
Yes.
We cannot proceed with
On
1
N.
ml.
No, then what will happen is the path is very narrow. So all
See,
the images
I
from
think we are
here also
running
come
short of time. So after this step, she is going to centrifuge the sample at a prescribed limit, means some 1400
Come down,
revolution or
but
1500 revolution for 20 minutes.
can take it
And the
first, but
final
the thing is,
pellet is the
interface
one
has to get
where
created.
the motile
That will
sperms
create
would be
properly
there.
this.
She will tell you the
Yes.
important point
But
is
if
when
you
you
are
are
good with your hand,
removing
you can
this
do that
pellet,
as well.
use another centrifuge tube, because wall of this centrifuge tube is containing to the side stuck up dead sperms and the pus cells. So if I just throw away the supernatant in this pellet and add the sperm wash media in the same centrifuge tube, your dead sperms are again going to come in the same motile sperm pellet. So after she has done the centrifugation, you will take this pellet and put it in another centrifuge tube and add a culture media for final wash before you are handing over the sample. You would like to add anything? Because we won't wait for the
Yeah,
outcome.
We will not do. So instead of, see, first centrifugation, I mean, now after, yes, after preparing the tube, we will keep it in the centrifugation for 20 minutes at 1500 RPM. See, I mean, it is suggested that you use 300 G. So either you use 300 G or you use 1500 RPM, that is equal. I mean, or you can play around with 14 and 1500 RPM. But don't increase the RPM above for 1500, because if you increase the RPM, it can cause the damage to the sperm. So less, I mean, suggested time and suggested RPM, if you use, there is less chance of getting damage to the sperm. If you increase the time and the RPM and then any centrifugation, it can create the ROS as well, plus the damage to the head of the sperm. So now we'll counterbalance the tube, put inside the centrifuge. Now ideal time is for first centrifugation is 20 minutes, or what you can do is you can put it at 1800 RPM for 15 minutes. Right? If you reduce the time and increase the RPM till 1800, there is no damage. But you cannot go beyond 1800 and you cannot go beyond 20 minutes. So now you remember 1500 RPM, 20 minutes. Right? Shall I start the centrifuge? Now I will not put for 20 minutes because we don't have time. We just assume that 20 minutes get over. Right now I am putting at 10 minutes. Now I can give tubes to everybody and they can practice if they want. No? Okay. Okay, so fine, no problem. You want this microscope, sir? Not okay.
We'll start. Can we switch off the lights now? lecture, he is just dimming the light. The idea of this presentation is to introduce you to various parameters in the semen analysis. Now we have done the initial examination, we have done the fructose viscosity, we have done the liquefaction, we have counted the sperms, we have addressed the issue of motility, and now we will see how semen analysis has evolved over a period of time and why these changes have been made and what is the meaning of each change and what is the meaning of each and every parameter we report for semen analysis. Ajay, how do you proceed with the slides? Yeah? Here, na? Okay. So this is the latest manual which has come in 2010, and this is the 5th edition of the WHO manual. The last version before this was 99, so there was a 11-year gap. And let me tell you that 2010 edition is the most unpopular manual. You will see many andrology labs in the world still using the 99 manual and not switching to 2010 manual. We will see why people are not happy with this manual. Now see, the changes in volume, in 87 it was 2 cc, over a period it is now 1.5 ml is the minimum volume. If you see sperm concentration, it was 20 million as the minimum sperm concentration per ml, which is now reduced to 15 million. The total sperm count is more or less same. The motility forward progressive was minimum 50%, now it is reduced to 28%. See the change in the normal forms, sorry. Okay. Change in the normal sperms is reduced from 14% to 4%. This is the main reason for unpopularity. So we are now saying that 96% abnormal in a semen sample is normal, and only 4% needs to be normal, and it's okay if you have 96% as abnormal. Now the published data till then, this 14% was based on IVF outcomes, in which there was a work in South Africa by Timothy Kruger and associates, which indicated that this strict correlation of morphology, the IVF outcomes differed dramatically at 14% cutoff, was the basis for this 14%. The basis for 4% is what? Instead of with this, you will be surprised that this is done only in about 1200 patient samples who were fertile in 8 countries in 1 year of coitus, in the preceding 1 year of coitus. Their average semen sample was used as to, and the statistical analysis was used to arrive at this data. So the population on which this normal range was based was a very small population in 8 countries. The criticism also was that this didn't include Asia Pacific, it didn't include black race, so it was only in Scandinavian and white skin population in 8 countries and only 1200 to 1300 patient data. And that's the reason this manual has not really clicked in a big way. Now there was somebody who asked me that what is viability and is there any difference between motility and viability, and which situations it is important. We will address it, but yes, the sperms can be non-motile but viable. In other words, one can even have a 10% motility and 50% viability. If I do viability tests, there are different types of tests. One is eosin-nigrosin assay, there is a hypoosmotic swelling test, there is a mitochondrial membrane potential test. So this all indicates polarized sperms in mitochondrial membrane potential. In HOS, a functional integrity of sperm membrane is judged, and only the viable sperms would show HOS positivity, or eosin-nigrosin stain, which we will be seeing. But why I am telling you this, as you will see, the main change has occurred in the normal morphology scores. So that's why it's important to understand morphology very well. Now this Semen quality is a surrogate marker. It's not, it doesn't tell you whether the sperm has capability of actually fertilizing a egg. Can it tell you? So what is, in a clinical situation, what is the test which can tell you about fertilizing ability of the sperm? If your couple says that they had a previous abortion, the fertilizing potential of husband's sperm is proven, because there was a history of abortion. Or if the patient tells you, I underwent an IVF cycle with so-and-so gynecologist, 4 eggs were fertilized, but somehow implantation didn't occur, so I am trying in a new IVF setup. So you know at least the fertilization event was definitely occurring. But barring that, if these two are not available, your count and motility can be absolutely normal, but these sperms may not fertilize the eggs at all, and that question remains unanswered only by semen analysis, and that's the biggest lacuna in any semen analysis. These are various laboratory investigations. I won't go into detail of all because we have paucity of time and our lecture will as such take time to address. But this you must know. Semen analysis is only about 60% accurate in predicting fertility. So as I told you, the reason that suppose you have round-headed sperms, then at least you know that this sample, though the count and motility is normal, morphologically abnormal sperms without acrosome, fertilization cannot occur. But if there is a functional incapability of fertilization, there is no way of judging that from the semen sample. In the first year of marriage, the pregnancy can occur with very low number of sperms. Many men with apparently poor quality semen still will have children. This is very important. Sorry. Okay. The shorter is the duration of fertility, the better are the chances of conception. Now this, let me put it this way. If you get a couple with 10 million count, with 20% motility, married for 6 months, there are good chances they will father a child. If you get a couple where the count and motility are absolutely normal, 60 million count, 60% motility, no morphologically abnormal, but the duration of infertility is 5 years and they were not using contraception, then the chance of fathering a child is very remote, because if it was to happen statistically, it would have happened in this 5 years, and that means there is some functional problem with this sperm. So the duration of infertility, if it is very high, in spite of count being normal, you know that there is some problem either in the semen or some problem in the wife which you have not picked up, whether she has ovulation difficulties or cervical mucus hostility. Sometimes the cervical mucus is infected, and grossly infected, it kills the sperm because of the reactive oxygen species damage. So you know that the duration of infertility is very important in assessing what is going to be the prognosis to the patient. In other words, the gynecologist will aggressively treat a couple with IVF or ICSI if they are married for 5 years with so-called normal count and motility, but may not choose to do aggressive treatment in a couple where the count and motility are subnormal, but they are married only for 8 months. So that is the take home. This I discussed with you that patients with apparently low count and motility but a positive PCT. So just now when somebody asked me what happens when the viscosity is high, what happens when the liquefaction is delayed, I said that if they have a good PCT, it doesn't matter. That is because if these sperms are able to reach the cervical mucus barrier, if they are able to penetrate and they form a reservoir of sperms at the level of internal os, then their chance of pregnancy is very good. They have overcome their difficulties of whatever was the issue. So a positive PCT is very important in pregnancy outcomes. These are various nomenclatures. I just wanted to use oligospermia is less of sperms, asthenospermia is less of motility, Teratospermia refers to morphological abnormalities. Azoospermia is volume normal, fructose normal, pH alkaline, sperms absent, as in cases of post-vasectomy samples, as in the cases where there is an obstruction at the level of epididymis. The junction between testes and epididymis, there is an obstruction. You will get azoospermia, fructose positive, good volume semen. Patient can do either epididymal sperm aspirate and IVF ICSI, or patient can do what is called as vasoepididymal anastomosis. Aspermia, no ejaculate. Patient fails to ejaculate, or very low volume of semen. We already discussed about it. If the semen volume is very less, which are the 4 situations in which it is very less? Okay, now somebody was asking me about ABCD, what has happened in 2010 manual, what is the grades and what is ABCD. Now till 2010, rapid progressive and sluggish progressive both were classified separately, and A was rapid progressive, B sluggish progressive, C non-progressive, D immotile. Now here MacLeod earlier had more than 4 grades. So MacLeod grade 0 was corresponding to non-motile, non-progressive was corresponding to grade 1, sluggish progressive to grade 2, and MacLeod 3 and 4 were taking care in rapid progressive. You understood? Now it has been simplified further. The new edition of 2010, again one of the reasons why it is unpopular, it wants to club A and B under progressive. So they say that its technicians are incapable of differentiating the rapid sperm activity in many situations. So to avoid the mistake, we will just give progressive, non-progressive and immotile. It is optional to subclassify them separately as rapid progressive and sluggish progressive, but the total progressive should exceed certain percentage. Now we are clear what is ABCD, what are grades, and what does it mean? So essentially it doesn't change the percentage motility which is progressive, but the subclassification is optional. If you are not very clear, you can club A and B together under only progressive motility. That's why some of you say so and so told me that you have progressive, non-progressive and non-motile. You can also write rapid progressive and sluggish progressive totaling progressive. So it doesn't change the percentage, but the information about rapid progressive is lost in only progressive. So you may not have a single rapid progressive sperm, but your percentage motility, which is only progressive, would remain the same. I hope this clarifies issues about motility. This is important to know that the semen diluting fluid, this is the content, this is essentially soda bicarb, formalin. You can use trypan blue to see the sperm better. If you have phase contrast, you may not need it. This we have discussed already. Formalin immobilizes the sperm, very easy to prepare, or it is commercially easily available. This she has discussed about macular chamber, so I won't go into detail. I have explained to you that you can use heat immobilized sperm. Any 10 sperms can be counted to get sperm count in millions per ml, and it is only 10 micron deep, and the ordinary Newbor's chambers is 100 micron deep. Newbor's chamber has overflow gutter, macular chamber doesn't have gutter. So in Newbor's chamber, what you introduce finally from your pre-diluted sample doesn't matter so much, because if you introduce more, the overflow gutter will take care of it. In macular, instead of 5, if you put 7 microliter, it makes a difference. So that's why, to answer your question, yes, IVF clinics use macular for simplicity, but there are also many precautions to be taken in macular chamber. The thing is, she mentioned you the counts without heat immobilization. But you can imagine for a technician to count motile sperm count is very difficult. The reproducibility will get lost. So it will be, the manufacturer recommends use of heat immobilization, in which case anyway you are introducing a additional step of heat immobilization in a beaker at 50 degrees by keeping 0.5 ml semen at 50 degrees for 5 minutes before you load the macular chamber. Now that has addressed all issues about what is the motility, how to score it, ABCD. It has addressed all the issues about use of Mechler, how to count in Mechler vis-a-vis Newbor's chamber. So in WHO manual 2010, you will not find a mention of Mechler at all, not even under optional. Okay. Now this I am going to take some time. This is a population of normal sperm by Pap stain. Now how we define what is normality? I told you that the normality reference range is the population of sperms obtained after a coitus from internal os of a woman. If I take 100 women and obtain, and if I see these are the majority sperms, I take that as a reference point. For us to know, a sperm head should have a breadth of 2 to 3 micron. It should have a length of 3 to 5 micron. The length upon breadth ratio should be around 1.5. The head should be perfectly oval. The acrosomal area should be 30 to 70% of the sperm head area. The acrosomal vacuole should be less than 1/3 of the acrosomal size. The cytoplasmic neck or the cytoplasmic droplet at the junction of sperm and the tail cannot exceed more than the sperm head size, so very easy to judge, and the length of the tail is around 45 microns. These form the basis of our what constitutes morphologically normal sperms. Now once you are aware of this, it is very easy for you to score what is normal and what is abnormal. So I will explain to you. Now this is completely normal sperm, but look at this. That's why I said whether this cytoplasmic droplet is more than the head? No. So it is still normal. But here it is approximately the same area. So this is a perfectly normal sperm. So oval sperm head, acrosome without vacuole occupying 30% of the area, a sperm tail which is about 45 microns, the head to breadth to length ratio, so length upon breadth is around 1.5, and this is again a normal sperm. Now I have wanted to show you subtle abnormalities. Now this is a sperm which is not perfectly oval, so this is not classified as normal. It has a 30% acrosome, but this is a pear-shaped sperm. This has a large cytoplasmic projection and a reduced acrosome. A sperm with hardly 10% area which is acrosomal, a normal sperm, a perfectly normal sperm, a perfectly normal sperm. So even in a population which is obtained for internal os, here also 60-70% sperms are normal, the remaining are abnormal. If that filter was not there, you will see that majority of sperms are showing subtle abnormalities, because now you know what constitutes normality. So any deviation from that, you are going to classify it as abnormal. This is a Shore stain to show you the same, a complete morphological normal sperm, completely normal sperm. Now you look at this sperm head, again a pear shape, sperm with short tail. This is abnormal head morphology, a normal sperm, sperm with a very short thick tail. This we have discussed, so I need not repeat it. This is the method for those of you who want to note down, that I have already outlined. You take 0.5 ml of semen, 5 ml of Pseudomonas reagent. Now if you get a patient who is say 30-year-old, and this I have again discussed, but I am just asking you the same question. 0.3 ml semen volume, pH is acidic, fructose is negative, and patient has azoospermia. What are the various possibilities? We discussed there are only 4 possibilities. So we narrow it down to incomplete semen discharge. By the way, 1 is the commonest. So don't jump to a conclusion that patient with absent fructose and a low volume is a patient with congenital absence of wax, because out of 10, 7 of them will be of incomplete semen discharge. So they partially ejaculate, but they don't ejaculate fully in a stressful environment, and that's the reason you get incomplete semen discharge. Second is ejaculatory duct obstruction. third is congenital absence of vas, and fourth is retrograde ejaculation. There are various methods to remove the spermatozoa content from urine. So, see, the pH is changing because the secretions are coming only from prostate. No? There is no seminal vesicle secretion. You understood? That's why it is acidic. So, in retrograde ejaculation, if you tell the patient that you collect the urine after coitus, but if he was to collect urine directly, the urine pH all of us know is 6. So, the sperms will get killed. But if you give them a culture media with 7.5 ml pH, give 50 ml of culture media and he produces 50 ml of urine after coitus, you will get a live sperm sample. And we have at least more than 10 patients who have conceived after IUI from a case of retrograde ejaculation and the sperm preparation done in our lab, where you have isolated the sperm sample from the bladder urine mix sample. Okay? Wrong answer would have been vasectomy or any obstruction in the vas. Vasectomy and obstruction in the vas is much higher and it doesn't produce negative fructose and low volume and acidic pH, because seminal vesicle secretions are still going to reach out. So this is again another wrong answer. Now what is other cells in semen and why they are important? The number of other cells in semen should be less than 5 million per ml. The number of pus cells in the semen should be less than 1 million per ml. Now, somebody asked me why you want to know whether there are spermatids in the semen, what difference it makes to anybody. You know, there are situations why it makes a huge amount of difference. Suppose my sperm count is 5 million per ml, but my spermatids are 10 million per ml. I know these patients is shedding the immature germ cells in the semen. So either the testes are exposed to high temperature in the scrotum, so he is probably wearing very tight underclothes, or he has a varicocele which has increased the testicular temperature, and that's why the sperms, spermatids are being shed in the semen, or he is exposed to some toxin where the sperm maturation is not occurring and they are getting shed. So it indicates a testicular stress. That is that the only reason? No. Suppose you have a situation, now this I want answer from the audience before I give the answer. If you have a patient in whom volume is normal, fructose is positive, pH is alkaline, no sperms are seen, and I get spermatid in the semen, should I do a testicular biopsy in this patient? Provided you have not mistaken pus cell for spermatid and you have accurately identified, that means there is no physical obstruction, so you are not justified in doing a testicular biopsy of this patient. And that's why in azoospermic individuals, if you identify spermatid, it saves the operation to the patient and referring doctor. That's why it's important. Is it the only importance? No, third additional importance. Spermatid and pus cells produce much more reactive oxygen species than any other cells. Pus cells are the topmost. So if pus cells are present, they will produce a 3000 to 5000 fold reactive oxygen species in the semen compared to any other cell in the semen. And that's why the number of pus cell allowed in semen is less than 1 million per ml. This would translate to an occasional cell, pus cell in the semen when you examine. Now people confuse occasional pus cell in the semen with occasional pus cell in the urine. They forget that in urine you are taking 10 to 15 ml sample, centrifuging, and then reporting that occasional pus cell. When you report occasional pus cell in the semen, even an occasional pus cell corresponds to 1 million because you are using uncentrifuged specimen. So when somebody reports 5 to 10 pus cells in the semen, and most of the time that report is wrong because they are immature germ cells, you know, you have to be very careful. I have seen 20 to 30 pus cells in semen, just like urine. That would correspond to 300 pus cells in the urine, just to give you idea. So somebody reports 25 to 30, the pathologists are mentally used to, judge it in the same context as the urine sample that you see commonly. No, you don't commonly see pus cells in semen. The reason you report it, because you wrongly identify pus cell and immature cells, you are unable to differentiate, but we will all learn to differentiate them. Now we have clarified why each cell is so important when you report. These are pus cells. How they differ from a immature germ cell? The outline is not perfectly round. The nuclei are lobed. And the granularity of cytoplasm, if you see, is very coarsely granular. This is a conventional Pap stain. Okay? Now we will also show you how a spermatid would look like. This is a macrophage cell with an ingested bacteria. This is another mononuclear macrophage cell. This is a macrophage cell. Now I want somebody to answer me, suppose I report 2+ macrophage cells. What difference it makes to anybody? Why should I report it? First of all, are you able to identify macrophage separately from pus cell in the semen and an immature germ cell? You will have to do a proper Pap stain and spend some time on the slide. But if you are reporting high number of macrophage cell, all of us know that they come into picture as a scavenger cell to remove dead sperms. So that means in this patient there are apoptotic sperms which are higher than normal. The sperm death is higher than normal. So this patient could be having anti-sperm antibodies, it could be having a low-grade infection, it could be because of some testicular stress, but it indicates increased sperm death. Commonest is infection and antibodies, but any testicular stress can produce a sperm death. So a higher number of macrophage cell is indicating to you that you have to look for sperm antibodies, you have to look for, so you can advise semen culture in this patient. And be very careful when you report. Now I think you will be careful in reporting pus cell, because such a high number of pus cell, you are actually saying that this patient has a serious problem in semen. This is another macrophage cell which has ingested so many sperm heads. You can see it has ingested so many sperm heads. Now we have already talked about sperm morphology, I have shown you, but for all of you to understand, one way was to look in the microscope. We had kept the microscope and show individual slides, but then I thought that will be too difficult for you to, but we will, if we have extra slides, we can give a couple of slides to them later, if the time permits, or they can even take home. So they can observe at their own comfort in oil immersion, because each one of you will have to spend some time on the slide. So we will try to see that sperm morphology evaluation is done. It depends on variety of factors. Ideally 200 spermatozoa should be counted under oil immersion with any type of stain. You can use H&E, PAP, GIMSA, Rapid Dip Quick, which is commercially available, or Leishman stain also. All these factors affect morphology evaluation. These are variety of methods in which you can use morphology. You can also do it under very high quality phase contrast imaging, but then somebody should be used to doing it. Otherwise, because phase contrast will differentiate between acrosomal area and the rest of the sperm also. Now, what is it that why morphology is important? Let me tell you that the ability to fertilize sperm, I told you, cannot be predicted by count and motility. So we have only one parameter in the semen which has direct linkage to fertilizing ability of the sperm. In other words, if your morphologically abnormal sperms are very high, the fertilizing potential of this semen sample is very poor, no matter what is the count and motility. That's the take-home message. So there was something called as multiple anomaly index. No, it had only 3 classification: abnormalities of head, midpiece and tail. So maximum score would be 3. And if your score exceeded 1.56, they saw that there was not a single pregnancy. So you can see that in spite of normal count and motility, if this was abnormal and if the multiple anomaly index was 1.5, pregnancies occurred. So they just suggested a cutoff for 1.6. At that time, the WHO manual was not talking about multiple anomaly index. So this came in 1988. There was no mention of multiple anomaly in WHO index. But then the next WHO manual introduced the same under the heading Teratozospermia index. But what they did, instead of 3 abnormalities, they said the cytoplasmic droplet also should be counted as an abnormality. So the score can be 4 in Teratozospermia index in WHO manual. It can be 3 in multiple anomaly index. Essentially the same, a different way of scoring. So we will see that. So WHO in 92 manual, see these people have introduced it in 88. WHO introduces it 4 years later and they just change the label to a Teratozospermia index and add cytoplasmic droplet to abnormality. So the maximum score now shifts as per WHO to 4. Now you will wonder why all these talks. Are there any sperm with multiple abnormality? Does it have a clinical relevance? So we will see that. This I had told you that the 14% cutoff had good scientific basis. People accepted it because look at the IVF outcomes. A morphologically normal sperm at 15%, the fertilization rate was 82% in IVF. A morphologically normal sperm, 14%, the fertilization rate dropped down to 37%, but more importantly, the pregnancy rate was 0. So your cutoff could differentiate between the fertilizing ability of the sperm between pregnancy and no clinical pregnancy in IVF outcomes. And that's why the earlier WHO cutoff of 14% was very well accepted by andrology lab because it had basis that this cutoff clearly differentiates between no pregnancy to pregnancy. So anything less than 14%, your pregnancy chance was 82%, a fertilization chance, and a take-home pregnancy in IVF was 26%, and it dropped to 0 pregnancy rate, and the fertilization rate dropped down to half if your morphologically abnormal sperms were higher than 14%. So well accepted morphology criteria. Most of the andrology labs, even in 2015, are still reporting on rapid progressive, sluggish progressive. So they have not adopted to 2010 manual either for motility or for morphology, but we all have to adopt. So we are now quoting 2010 manual in most of the report. But this was the reason why it was not very well accepted. Now you will see that this is one sperm showing how many abnormalities. Abnormalities of head, abnormalities of cytoplasm, abnormality of tail, a thick tail. So 3 abnormalities in Teratozospermia index, the score will be 3 or close to 4. So it is possible to get such sperms in the semen. Again the same, very high Teratozospermia index. Again the same. So this answers your question, is it seen? It is seen many times, but some semen samples will be full of it. A normal semen sample will show this occasionally. Another such sperms. Now we come to what is the viability. The thing is, if I have a non-motile sperm and I have just reported them as non-motile and non-viable, this patient is a patient of necrospermia. That means all sperms are dead. He has no chance either in a normal situation or with IVF or ICSI. No matter what, he will never conceive with his own sperms. That is what you report when you say all sperms are dead or non-viable. But if I report all sperms are non-motile, does it mean that he has no chance of pregnancy? It doesn't mean that. Because there could be some sperms which are non-motile but viable. So it's important to differentiate between viability and motility. and that is common practice is done by eosin nigrosin stain. Very easy, 1% eosin, 10% nigrosin. Just mix it, allow it to remain for 5 minutes, put a cover slip and examine under the microscope. Very easy. These are unstained sperms, so they remain white. That means they have not picked up the dye, and this is a supravital stain. So these are viable live spermatozoa. Okay? Now this is to show you how a dead sperm would appear. The one which is stained pink has taken the dye, indicating it's a dead sperm in eosin nigrosin stain. The one which is showing white color, this one is a live sperm. So now we have also learned why it is important to score viability. Now Dr. Ajay will tell you that we had recently one case in whom all sperms were non-motile. The percentage motility was hardly 2 or 3%. And then we did a flow cytometric based assay called mitochondrial membrane potential, and that showed almost 60% were showing mitochondrial motility. He will talk about it later. In other words, these were viable sperms with intact mitochondria, but somehow the specimen sperms were non-motile in the sample. Then when we looked carefully, under higher magnification, these non-motile sperm, most of them were showing vibratory motility. So that was not completely immotile, but they were showing such a minute motility that you would not, unless you looked for it, you would not pick it up. So important to differentiate between viable sperms and non-motile sperms. When you report everything is non-viable, that means patient can never conceive and he should stop treatment because they don't revert. Any patient with totally non-viable sperms or necrospermia, I haven't seen a single case where he converts into somebody with viable sperm. So you are writing off his future, remember that. Now this is to show you different types of abnormalities. These are, you saw the earlier heads. Compared to that, this is a large headed sperm and you will call it as abnormal. Another very large headed sperm. So instead of your normal dimension of 3 to 5 micron, it is much higher, also has a very thick mid piece. Now we have one more case. 28-year-old male patient, count 40 million, sperm motility is good, almost 25% total progressive motility, but morphologically majority of sperms are round-headed sperms, so they don't have acrosome. Can he conceive with a normal pregnancy by or IUI? These are the round-headed sperm, what we call as a cases of globosospermia. So I used to feel the answer is simple. These sperms don't have acrosome, so they cannot fertilize on their own. So you can't succeed with IUI or even IVF, but you will definitely succeed with ICSI. All you need to do, they are motile sperm, they are live. There is a DNA content in the sperm head. So I pick up the sperms and inject in the egg by micromanipulator and you will see pregnancies. But for some reasons, these patients do very poorly with ICSI also. So not only they are not going to conceive with IUI, IVF, even with ICSI their chance is going to be very poor because the fertilization rates with these sperms, even on micromanipulation, drop down very considerably compared to a normal sperm. This is similar case, you can have a total globosospermia. We had recently a patient from whom this slide is taken. He has 100%, and there are reports after report showing normal sperm count and motility without realizing that this is HN. Yeah. Without realizing that sperm has no acrosome. So that's why it's so, I am spending so much time on morphology. This is again to show you all abnormal amorphous sperm. See, you know that this is a what we call as a pinhead sperm, no nuclear material, but it will move because it has a tail. Okay. Similarly, this is a larger than normal and the shape is not oval. What was our classification? The head shape should be perfectly oval with round configuration. So when I said initially 3 to 5 microns and 2 to 3 micron breadth, perfectly oval, 30 to 70% acrosomal area, acrosomal vacuole less than 1/3 the acrosomal area, midpiece if present has a cytoplasmic droplet lesser in size than the sperm head, and tail length should be 45 micron. Any of this is not fulfilled, it goes as abnormal, so all these will go as abnormal. Unless you are careful enough, you will see all 4 are abnormal. But if you are not careful, you are going to give everything okay in this patient, because they are not grossly abnormal. Again an abnormal sperm. This is just to show you more and more abnormal so that we don't have enough time to show you individually. So I thought I will project different types of sperms and clarify the doubts here. See, now this is a sperm head with lot of vacuoles. So this will go as abnormal. Now this is a sperm which is larger. It has also got vacuoles. So it goes not because of vacuoles, it goes because of very large sperm head with mega acrosome, much larger than the normal. In fact, the acrosome is projecting outside the sperm head. It's not a part of sperm head, it is well outside the sperm head. So this is, all this would go as morphologically abnormal sperms. This is very obvious, I need not spend time. Again, very easy to understand, everything abnormal about them. This is midpiece disorders, so they are all bent. Now see, this is a midpiece abnormality because the size is almost equaling head. See, asymmetrical insertion of tail. So I am trying to show you all kinds of abnormality. This is not oval, so it becomes abnormal because this is a round sperm and not an perfectly oval sperm. Thickened midpiece and very elongated large tail. Then we come to tail abnormalities. This is very easy to identify, very rudimentary short tail. You will see patients in whom this constitutes 60-70% of the sperms. Short coiled tails, again short and coiled tails. This is agglutination of sperm. So when you see either head to head, this is tail to tail agglutination, you know that you have to look for 2 things. One is an anti-sperm antibody or a low grade infection. This abnormality is very unique. Somebody who has all pinhead sperms will have more than 90-95% pinhead sperms. So these are sperm head without any nuclear content and only one sperm, but again not normal because it is a bent midpiece. Now this is a very subtle abnormality. Unless you are careful, you won't pick it up. Look at an apparently normal looking sperm with a small acrosome. What was our definition? 30 to 70% of the sperm head area. This is not happening. Here also it is not happening. Here also it is not happening. Here also it is not happening. So this patient has very poorly developed acrosomal cap. So looks wise it looks fine, nothing majorly abnormal. Even this sperm, hardly any acrosome. So if you are careful, you will see that there are acrosome, but they are very poorly developed acrosome. I am trying to show you from gross to very minor abnormalities so that you are well qualified to report them. Now what is the importance of HOS test? We expose this sperm to hypoosmotic fructose solution and look for tail curling. Earlier it was marketed as a test for fertilizing ability of the sperm. But now we know it doesn't pick up the fertilizing ability, but you can pick up viable sperms with this method. So in other words, what is the significance of a positive HOS? That means these are viable sperm. What is the clinical utility? Suppose I am a doctor who is doing micromanipulation or ICSI, and I have a pool of non-motile sperms, and before choosing which sperm to inject, I can't do usine nigrosin stain to look for viability. because then I am killing the sperm. So how do I judge which sperm to inject if it is non-motile? I have no way of finding out by any other method. But if I expose this sperm sample to HOS solution, those with tail curling are the ones which are non-motile but viable. So I will pick up that sperm and do ICSI. That's the importance of this test. Now this is another case just to show you that he has a low sperm count, and FSH which is normal, LH which is normal, and testosterone which is just a low normal. So the question is his testicular function normal? Means he may be normal in terms of erection, but is he normal to produce a normal semen count? Can you judge it by his FSH, LH, testosterone report? No. A normal FSH doesn't mean normal testicular function. See, all of us have to remember that patient can, almost 2/3 of the patients with low sperm count will have normal FSH, LH, testosterone. So that doesn't tell you whether the testicular function hormonally doesn't tell you that whether the sperm production in the testes is normal or not. But a high FSH definitely means an abnormal testicular function and significant damage to the testes. So if you see a high FSH of say 20 plus, you can be sure that the patient cannot produce a sperms of any good quality, because there is a significant damage to the testes. This is a very unusual picture. The reason I am trying to show you is very difficult to get this. You see, this is a spermatid, but it has still not shed its tail. So it's a binucleate spermatid in the process of spermiogenesis, that is, it is moving towards being a sperm, but it has just started developing a tail. These are cases in which you can actually see a lot of bacteria, just like you can see a lot of bacteria without pus cells in the urine, you can also see a lot of bacteria without pus cells in the semen. These are candida in semen. So you can see all types of abnormalities. Then we come to sperm DNA fragmentation test. Sperm DNA fragmentation test is a test which will tell you whether the patients, we tried to answer that if a semen count motility is normal and patient is not conceiving, then this is the case you need to know the fertilizing ability, so you require sperm function assays, and one such assay is sperm DNA fragmentation, which will tell you that if the DNA fragmentation is increased, the chance of pregnancy is going to be very less. So more than 30% DNA fragmentation, in spite of normal count and motility, would suggest that this patient doesn't have a chance both with IVF or normally. So you can advise this patient accordingly. I think we have come to end of this topic. And how much time we have? We have some time. I would tell Ekta to show the remaining of this density gradient separation, and after that the last topic I will ask Dr. Ajay to speak briefly about the sperm function assays, because that's the closing gap we want to close as to what options are available to patients. If semen doesn't tell you the complete story, what else can be added? And then we will keep some time for question answer, and I hope that will address most of your issue. The morphology evaluation, microscopes are kept, slides are kept, and I am available. Dr. Ajay is available for those of you who want to see under microscope. All the material is kept. So I will hand over to Ekta now.
Hello.
Camera. Sorry? Yeah, we can show on the slides.
Then
Yeah.
So we have shown you pus cell. We will show you there were different types of germ cells included. They are missed out in this lecture.
We can show it on the slides.
But I had included them in other cells in the semen, so let's see if they are there. Many pictures there. After other cells, no? He is kept.
Okay.
I think we will have to show you on slide. We have many slides with lot of schematic and
Process.
lot of macrophage cells in the same. So you can even take them home. But for those of you who want to see, we'll try to project on this.
This, yes.
So you can actually.
You can use it.
So till then we can start.
Yeah. Just you just. After 20 minutes, now what we get? Now back to procedure, please. Yes, sir. Sir, आपको question है.
Sorry, sir. Last PPT, oligospermia was mentioned for 20% and 20 million. And
Now it is 15 million.
15.
Now the cutoff is 15 million.
so less than 15% we should mention
Oligospermia.
Less than 15 million.
15 million per ml is the cutoff for concentration.
we use counts or we use concentration because both the things are different.
No, both are same.
Both are same.
Both are same. Concentration per ml or count per ml is same. So there is no difference. There is a term, what is important is total number of active sperms per ejaculate. That is what finally counts. That is, you say count per ml is, suppose I have 20 million sperms per ml, but I have a volume of 0.3 ml. Then the content of normal sperms, active sperms, is going to be 20 million. 0.3 means I have 12 million total sperm, out of which only 20% are motile. So my motile sperm population could be 2.4 million. So that is what I mean by total number of active sperm per ejaculate.
I have to rephrase the question. Suppose a person, okay, at one stage of his life has a count of say, suppose 50 million, okay. Maybe 6 months later, due to some problem, some epididymis or something, some problem, those secretions are reduced. He does a sperm count again, the concentration might be, okay, maybe 100 million.
So that's why I am trying to tell you what will change is the concentration. So that's why you have to look at concentration and active sperms per ejaculate. I will expand my answer. Suppose I have 8 million count per ml, but my volume is 8 cc. Then I have actually 64 million sperms, out of which 20% are motile. So I have 12 million motile sperms with 8 million count, while I had 2 million motile sperms with 20 million count. So there is another parameter which we report as total number of active sperms in the whole ejaculate. That means you are counting the total number of sperms. Percentage motility gives you what is the population of active sperms per ml, and multiplied by his volume will give you what is population of active sperm in the whole semen sample. So that takes care of any volume variations.
Lazy to put that point or whatever routinely we are doing, that is okay.
No, our report, if you see our report, it mentioned total number of active sperms per ejaculate. Because then the volume variations which result in concentration variation are addressed. Because that can't change. Suppose sometimes he produces less volume or more volume, the number of active sperms in the whole sample don't change.
Multiplication of volume.
You can give your mail ID, we will mail it to you.
हो गया. Just a minute. CV 00 हो जाए.
Shall we move to the procedure? Yes. You all remember what we did before the lecture? See, now I am removing the tube from the centrifuge after 20 minutes. Fine? So what we get is pellet of the motile sperms. Now see, because of the interface, all the abnormality or the debris or pus cells, whatever is there, will stick here, and whatever you get at the bottom is a pellet. This is a motile sperms, concentration of the motile sperms, normal motile sperms. Right? So there are 3 layers again. This is the seminal fluid here. Then here you will get the debris, and below at the bottom you will get the pellet of the motile sperms. Now we need to change the tube. So we remove the supernatant, transfer the pellet into the next tube, add sperm wash medium, and centrifuge it again for 10 minutes. We have to give 2 centrifugation. The reason is we are using silica particle when we do the density gradient. As sir mentioned that they can cause many damage to the cervix. That is the reason we have to get rid of those silica particles. For that we give 2 washes with the enough medium. If you don't use the enough medium, good quantity medium, then you will still find the silica particles in the sample, and that can cause the uterine contraction. So now remove the supernatant. Be careful, otherwise you will disturb the pellet. Go in a circular manner, so you will take all the debris which are lying there at the surface of the tube. Now transfer this pellet to the another tube, because this tube is contaminated. So when you add medium in the same tube, all the contamination will come below and will get mixed with the pellet. New pipette. Take the pellet, transfer it in the new tube. Add 4 ml of this sperm wash medium. Mix it properly. And again centrifuge it for 10 minutes at same RPM, 1500 RPM. In between we will continue with the swim up. Now let us move to the swim up technique. Now, unlikely with density gradient, in swim up we take the sperms which are moving upward, not the pellet, right? See, can you see this hazy part just above the semen sample? That is the motile sperms. So these are not very good motile sperm, but you have to take the portion from the top, at least half ml of the swim up, yes, half ml of the medium from the top. Take the conical tube because we are going to centrifuge this. Add sperm wash medium. Two ml of this sperm wash medium. Here we are not using silica particles, so you can take 2 ml of the medium. Mix it well and centrifuge this for 10 minutes at 1500 rpm. We will give only one wash because we are not using silica particle here. We just concentrate everything at the bottom, so we have a good result, good concentration of the sperm. Or else if you have very good sample, you just take the drop from the top, evaluate the sample under microscope. If you feel that this is the proper amount of the motile sperms are present in the sample, you can take 0.5 ml of the sample from there itself and you can examine. So no need to centrifuge. But that is in case of very good motility. I mean, if you have 50-60% of motility, in that case you can get such a good sample. Confusion or clear? Sure? Both the methods? Now after 10 minutes, we remove the supernatant. Now there is no need to change the dish, change the tube. Add sperm wash media again 4 ml. Give it a second wash with 10 minutes, same RPM. After that, we remove supernatant, add 0.5 ml of the medium, mix it well. We will check the count, what is the motility post wash, and then you can examine the sample. Same step we have to repeat. Right? Now one thing which I would like to say, when you are using the medium for IUI, always incubate the medium at least 2 hours prior to the process. It has to be at 37 degree temperature and it will take at least 2 hours to get the uniform temperature. That is the reason whenever you start your work, first thing in the morning you start your heating block, put the medium for the incubation. In density gradient, you can prepare the tubes and can put for the incubation. If you know that you are going to get 10 patients or maybe 5 patients, prepare the tubes accordingly and put inside the incubator. Remaining, once the medium is in incubator, it will not go to the refrigerator because the protein denatures when the temperature changes. So be careful with this. Incubation is important. Any queries regarding the procedure? Heating block, yes, this is a heating block. 37 degree temperature it provides. Mini incubator. I mean, this is just for the temperature. For gas, you have to buy, if you are doing IUI, it is not required because all the maximum mediums are Heap's buffer. who are used in IUI. So you don't require the conventional CO2 incubator, but you can use the normal incubator. But keep the incubator separate. Don't mix with the microbiology lab. So when you're doing IUI, you put the separate setup for that. That is the better. And you have to process the sample within 1 hour. Ideally, you should not take the samples from the clinics which are very far away from your lab. But at least within half an hour, sample should reach to your lab. No, after the processing, you can examine till half an hour. But before processing also, it should reach to your lab within half an hour. So in another 45 minutes, you will complete your procedure.
While handing over the patient with the sample, do we need some information also about the sample?
Yes, ask him to keep it in the pocket so it is near to the body temperature.
Information regarding the sample.
Yes, you can give count. You can give count. What is the count in the sample? Yes. What process you have done, whether swim up or density gradient. Pre-count, post-count. Yes, that should be there.
Motility also.
Motility also, yes. Count and motility you have to give. So the doctor also knows what is the. Yes.
So, is it possible to get after harvesting or after the procedure to get the counts as high as 50-60 millions?
Yeah.
We can.
Yes. You will get.
Because some gynecologists object on that. They say that it's not possible to.
Total motil will remain same.
Yeah. Yeah. Right.
That care you have to take. You cannot do more active stuff
No.
than what were present originally in the semen.
Centrifugation, you're concentrating the pellets. That's why the count per microliter is more than what it is with Sperm. But the overall total motile form will remain same.
Yes.
If it's higher than the original total.
Just because you are concentrating everything, you are getting more count.
Overall, it's the same.
That protein present in the hamstring fluid also that increases the motility.
Yes. Same.
So motility increases, but because of
Yes, motility increases because there is a glucose present in the medium.
Yeah.
So that is the reason motility is increased.
Increases.
Definitely motility is
Enhanced.
increased. Yes.
Enhanced.
Yes, yes.
Rewash is not required.
For what?
Technique also.
Pre-wash?
Semen rewash is not required.
Semen pre-wash with what, sir?
With media.
With media. This is both the ways.
She did swim up first and then proceeded with the wash. Or you can do wash first
Reverse.
and then swim.
Yes, that can be possible. I mean, you can do reverse. See, take the sample, divide in 2 parts, process by both the technique. Whatever is giving you better result, you follow that. Simple.
But most of the time we are not informed that we are going to get the sample. Then how we can remove the media and keep it to us?
So directly you get the sample.
Most of the time.
Then you have to, actually you have to keep the criteria for your lab that we will not process such kind of sample, because you have to, make the gynecologist understand that this is the procedure which has to be followed. So you should inform us 2 hours prior at least before getting the sample.
And we cannot again keep it in fridge.
No.
It is better to get information.
Yes. That is the only way out. Yes, that is the only way out. You have to get the information at least 1 day prior, or maybe few hours before. Now, I think this is done. Yes. I just want to show you the post-wash, so you can get the idea what is pre and what is post. That is the only thing which is remaining now. I will not centrifuge again, we will just assume that this is the second wash, and now we will check the count. Yes, just 5 minutes, I am done. This is the palette. Now I will remove the supernatant.
function essays. No, I will try to project. I will project the morphology. No, we will project on the whole screen. So you start.
So they are not interested in seeing the count?
The talk on functional essays and then we will go to microscope project.
Okay, so till then, you slide it. I'll finish it
So
quickly.
they don't want to see the count?
First, we'll see the count.
Just 2 minutes.
Yeah.
It's done now. मैम मेरा पिपेट कहाँ गया? पिपेट कहाँ गया मेरा? येलो पिपेट है ना मेरा? पिपेट मेरा येलो पिपेट हाँ इट इज हियर. Yes. I already told you. See the difference. See the difference between the motility. See, we have already given the one wash, so you can see that, they are not moving properly, not moving freely because of the silica particle. But definitely there is a difference. See the difference in progressive motile sperms. These are all progressive, but if you see the previous one, pre and now post, there is a difference in motility. They are much more faster than the previous one. No.
If you over
do the
centrifugate, then you get a lot
centrifugation
of
for a
dead
long time,
sperm.
it can, cause the damage to the sperm and they can get non-motile.
Even improper storage of the media makes a big difference. Then you won't get the same result.
Yes, always increase.
Depends
Concentration.
Concentration will increase, the count will not.
Count will remain same. Concentration will get increased.